Hey everyone, welcome to This Explainer. Today, we're diving straight into a condition that is so frequently misunderstood, often hidden in total secrecy, and heavily stigmatized: binge eating disorder. We are going to rely strictly on the latest clinical data, including the DSM-5-TR guidelines and the 2025 JAMA Review, to completely demystify it. By the end of this, you're going to have a crystal clear understanding of what this disorder actually is, exactly how it's diagnosed, and the incredible evidence-based treatments that are literally changing lives.
Section 1. The most common eating disorder. So, let's kick things off by getting real about just how common and, honestly, how hidden this condition actually is. You know, when we hear the term eating disorders, our brains usually jump straight to anorexia or bulimia, right? But the data paints a totally different picture. Binge eating disorder, or BED, is actually the most common eating disorder in the United States. It has a lifetime prevalence of roughly 0.9 to 2.6% of adults. That might sound like a small percentage, but we are talking about millions of people. Millions of people suffering, often in total silence, because the intense shame attached to this disorder keeps them from ever seeking help. And it's actually noted as the fastest growing eating disorder worldwide in the community right now.
Now here's a super important nuance. BED can happen to absolutely anyone, across the entire weight spectrum. You cannot, I repeat, cannot diagnose someone just by looking at them. But the clinical data does show a really strong link to overweight and obesity. In clinical samples, about 42 to 71% of folks with this disorder also have obesity. So naturally, it overlaps with conditions like type 2 diabetes, hypertension, and metabolic syndrome. But it is so crucial to remember that the disorder itself, it's about the clinical behavior and the deep psychological distress. It is never just a number on a scale.
Section 2. Defining a binge episode.
Okay, to really wrap our heads around this, we've got to look at the official DSM-5-TR criteria. People throw the word binge around all the time, right? Like, I binged that TV show, or I binged on pizza last night. But clinically, it has a very strict, specific definition under Criterion A. Basically, two things have to happen at the exact same time. First, eating a definitely larger amount of food than most people would eat in a similar time frame, usually a specific window of less than 2 hours. And second, and this is the absolute kicker, it has to be accompanied by a profound sense of losing control. The person feels totally, hopelessly unable to stop eating or control what they're having. It's not just overeating at Thanksgiving, it's an overwhelming, highly distressing compulsion.
Section 3. Diagnosing signs and symptoms.
Moving beyond just the sheer amount of food, we have to look at the deeply personal, psychological toll this takes. This is Criterion B, the associated features that make these episodes so incredibly traumatic. To get a clinical diagnosis, you've got to experience at least 3 of these isolating features. We're talking about behaviors like eating way faster than normal, or eating until you're uncomfortably, even painfully full. A lot of times, people are eating massive amounts of food when they aren't even physically hungry. And because of that intense shame we talked about, they'll often eat completely alone just to hide it. The aftermath is heavy. It's a wave of feeling totally disgusted with yourself, depressed, or just carrying this crushing guilt. And you know what usually triggers these episodes? It's mostly negative affect, basically just being in a really bad mood, along with interpersonal stress, feeling restricted by diets, or even just pure boredom.
Now, how do clinicians actually measure how severe the disorder is? They track the frequency. The DSM-5-TR says these episodes have to happen, on average, at least once a week for 3 months to be diagnosed. From there, it scales up. We step from mild at 1 to 3 episodes a week, to moderate at 4 to 7, severe at 8 to 13, and all the way up to extreme if someone is suffering through 14 or more of these episodes in a single week.
Section 4. Distinguishing BED from bulimia. If we want to really destigmatize and treat this, we have to know exactly what we're dealing with. Historically, diagnosing eating disorders could be a bit tricky because the symptoms often overlap. But here is the big differentiator: Criterion E. It explicitly states that binge eating disorder is completely separated from bulimia by the total absence of regular compensatory behaviors. Think about it. In bulimia nervosa, a binge is followed by an attempt to somehow undo those calories, right? Through self-induced vomiting, misusing laxatives, fasting, or working out compulsively. In BED, none of that happens. The binge happens, the intense distress and guilt crash down, but there is no purging afterward.
Section 5. Psychotherapy First-Line Treatments.
All right, now that we've mapped out the symptoms, let's transition into some actionable hope. Because the truth is, we have incredibly effective evidence-based treatments that tackle both the psychological and the behavioral sides of this disorder. Cognitive behavioral therapy, or CBT, is basically the absolute gold standard here. It's the first-line psychotherapy for BED.
Usually delivered over about 20 sessions across 6 months, it directly targets that intense over-concern with body shape and weight while helping to just normalize eating behaviors. And it works wonderfully, hitting around a 50% remission rate by the end of treatment. There are also lower-intensity guided CBT options using manuals that show huge benefits. Then you've got interpersonal psychotherapy, or IPT, which dives into relationship issues linked to the disordered eating, showing similar long-term success to CBT. Or for folks dealing with coexisting impulsivity or emotional dysregulation, dialectical behavior therapy, DBT, is a fantastic second-line option that teaches vital emotion regulation skills.
Section 6. Medication and Combined Therapies.
So let's see what happens when we bring modern medical interventions into the mix. Because while therapy is amazing at cutting down binge frequency and healing the psychological side, it usually doesn't lead to significant weight change on its own. That's where pharmacotherapy comes in as a great complementary option. For moderate to severe cases, lisdexamfetamine is actually the only FDA-approved medication right now. Approved back in 2015, it does a phenomenal job at reducing binge episodes and even produces modest weight loss. But there is a catch. It's a stimulant. That means doctors have to be super careful, they have to assess for cardiovascular disease before starting, and keep a really close eye on heart rate and blood pressure during treatment. You also have to watch out for potential dependence and know that if you stop taking it, weight regain might occur.
Beyond that FDA-approved route, clinicians sometimes reach for other off-label medications. A 2025 network meta-analysis showed that topiramate actually ranked the absolute highest for stopping binges, and it helps with weight loss. But it comes with a pretty heavy side effect burden, mostly this cognitive brain fog, so doctors have to ramp up the dosage incredibly slowly. Then there are SSRIs and second-generation antidepressants. Since a huge majority of patients are also battling psychiatric comorbidities like mood or anxiety disorders, SSRIs can be incredibly helpful for those overlapping symptoms, while also cutting down on the binges. Just keep in mind they generally do not help with weight reduction, and the American Academy of Pediatrics actually noted that, for treating BED specifically, SSRIs haven't always performed better than a placebo.
Now let's pull it all together. When you look at the 2025 Grillo randomized controlled trial data, the numbers are just mind-blowing. They looked at patients with both BD and obesity. Check this out. Treatment with CBT alone had a 44.7% remission rate. Lisdexamfetamine alone set at 40.4%. But when you combine them, when you bring CBT and lisdexamfetamine together, you get a staggering 70.2% binge remission rate. 70.2%. It far outperforms either treatment on its own. Plus, the medication arms drove even greater weight loss. This perfectly illustrates that hitting this disorder from both the psychological and physiological sides is often the ultimate key to true, lasting remission.
So, now that we've completely decoded the science, the strict diagnostic criteria, and the proven treatments, we have to ask ourselves something really important. How can we use this knowledge to finally erase the shame surrounding binge eating disorder? We know for an absolute fact now that this is not some lack of willpower. It's a highly prevalent, deeply distressing clinical condition with clear biological and psychological roots. And most importantly, it is highly treatable. I mean, if a staggering 70% remission rate is possible with combined therapies, you have to wonder how many people out there are currently suffering in total silence just because the stigma makes them too terrified to ask for help. I'll leave you to think on that. Thank you so much for joining me for this explainer, and keep learning.